Talk this afternoon is Autonomic Dysfunction in Parkinson's Disease, and our speaker is Dr. Justin Phillips. Dr. Phillips is a neurologist with the Norton Neuroscience Institute and focuses his practice on movement disorders with a particular interest in Parkinson's disease. He's a graduate of Center College, where he majored in psychobiology and philosophy. Prior to pursuing a career in medicine, he worked in a pharmacy after graduation. Dr. Phillips attended medical school and did his residency at the University of Louisville, where he was reminded of his love of the brain. He did a mini fellowship in geriatric neurology during residency and completed a movement disorders fellowship at the University of Kentucky. Welcome, Dr. Phillips.
Thank you. Let's see if I can get my screen shared. Okay, thank you. I think we got it. All right, so thanks, Dr. Cooper. Today, I'm going to talk about autonomic dysfunction and neurologic disorders. Most of my focus, obviously, is going to be on Parkinson's disease because that's my specialty, but we will delve a little bit into autonomics in general. And a very brief review of the autonomic nervous system from the standpoint of anatomy and that sort of thing, and then kind of just talk how this relates, really with a focus on things that primary care doctors are probably going to see, related to this in their practice. Disclosures, I have none. Learning objectives, review the anatomy and physiology, recognize the role of the autonomic nervous system in daily practice, understand the causes and epidemiology of autonomic dysfunction, and then evaluate and manage these autonomic symptoms in patients with neurological disorders. And so, for me, looking at a group of patients with Parkinson's disease, we look at the autonomic nervous system and how this affects things like cardiovascular, gastroenterology, and genitourinary. And those are kind of the big things that I see. And honestly, that makes up a lot of the complaints I see in my Parkinson's patients, more so than motor symptoms. Estimated prevalence in patients is as high as 80% of some kind of autonomic dysfunction. And we find that non-motor complaints are, some of the most significant contributors to dysfunction and have a significant impact on quality of life. Constipation is probably the most common. Orthostatic hypotension is a very common issue for me to encounter here in the clinic. And then, of course, urinary symptoms as well. So we'll kind of focus on those as the kind of big three for our Parkinson's patients. And so, remember the sympathetic nervous system is primarily housed in the thoracolumbar spine, and then synapses and ganglions, and then goes to the target organs. We'll review, that the neurotransmitters for this presynaptically are acetylcholine, and then postsynaptically for most of them, except for sweat, is norepinephrine. Parasympathetic is the craniosacral, and synapses on the target organ, and acetylcholine primarily is the neurotransmitter for both of these. And so this will be important when we talk about how some of the things we do medication-wise, iatrogenic things, may affect the autonomic nervous system. And so here's just kind of a little review slide of, the different targets and, how the sympathetic versus parasympathetic may affect them, pupillary response, salivary, heart rate, the bronchi. And so if we look here, we see, betas and alphas, and we think about adrenergic receptors, and we probably don't think about them normally when we're prescribing medications that are beta blockers or beta agonists and that sort of thing. We don't think about the autonomic nervous system per se, but there's always kind of a cause and effect back and forth. And so that's something we have to keep in mind, looking at patients with, these varied disorders. Again, kind of another way to look at, blood pressure increases and decreases, or heart rate increases and decreases based on how we are using sympathomimetics versus anticholinergics, or, beta receptor antagonists, as far as how they affect heart rate or sweating as a side effect. And so, we see anticholinergics on the bottom row and cholinesterase inhibitors up on the top row there. And, it's a common back and forth that we see. Patients may be on medications that have pro and anticholinergic side effects, and these things have to be taken into account, looking at what's the goal and what are we treating, and are we using medications that have effects opposite of one another. more of that with the adrenergic system, and decreased and increased sympathetic and parasympathetic function, dry mouth, urinary retention, all of those things. So let's talk about dysautonomia or malfunction of the autonomic nervous system. And so there are a number of things that can contribute to autonomic dysfunction in patients, and you'll see actually at the bottom there, iatrogenic. And so medications is probably one of the biggest causes of autonomic symptoms is a side effect of a medicine. So, we treat blood pressure with a beta blocker, but then, you have the opposite, or you treat, asthma with a beta agonist and you have the opposite. So side effects can certainly contribute. Autoimmune autonomic neuropathies can occur. There are inherited autonomic peripheral neuropathies. In my case, a lot of what I see obviously is related to autonomic dysfunction in synucleinopathies. There can be structural lesions, inflammatory and autoimmune types of things. You see that in MS, or even spinal cord injuries can contribute to it. But probably the most common cause is going to be an autonomic peripheral neuropathy, but not an inherited or inflammatory one, but related to diabetes. And so I do focus a little bit on that here. Again, I'm mostly going to talk about Parkinson's disease, but that would be remiss if I didn't touch on this, particularly with in regards to primary care, because a lot of these folks maybe never make it to see a neurologist, but a lot of the autonomic dysfunction is probably primarily related to diabetes, and obviously in this part of the country, this is a big problem. And I see probably in my clinic almost as much autonomic dysfunction related to this as I do to synucleinopathy. So this is kind of my attempt at some epidemiology to see about how many people might be affected by this comparatively to the synucleinopathy. So as many as 9.3% of Americans, or a little over 30 million Americans with diabetes, pre-diabetes, which can also cause neuropathy, is estimated to be much higher, a little over a third of Americans. And then when you look at a population similar to kind of what I'm seeing in my clinic here with a geriatric population, close to half have at least pre-diabetes. So that's a huge portion of the patients that I'm seeing, and that a lot of primary care offices are seeing and managing, have at least pre-diabetes. And so at least pre-diabetes does predispose you to autonomic neuropathy. And so depending on kind of how you define that, early autonomic neuropathy can occur up to as high as 15% and as high as 65% after 10 years. And so some of these folks that have had diabetes or borderline diabetes for many years will often have some autonomic dysfunction. This is the study from Oxford obviously doesn't necessarily correlate with our epidemiology here, but when you look just kind of community prevalence of autonomic neuropathy, up to 16.7%. And so if you limited that just to people who have diabetes and not even pre-diabetes, then you'd have a prevalence of nearly 1.4% of the population with a diabetic autonomic neuropathy. And compare that with something like multiple system atrophy, which always shows up on the differential when people have this, with a prevalence of lots of zeros before the 2%, or even Parkinson's disease, with a prevalence of 0.3% for those over the age of 40. And about half of those develop neurogenic orthostatic hypotension. So probably nearly tenfold more likelihood if somebody has an autonomic neuropathy or has neurogenic orthostatic hypotension that's from diabetes. And so that's something that probably needs to be screened for. There's a great paper with a task force for that on kind of ways to do that. But I'll go back to management of what I've deemed here the big three from a Parkinson's standpoint. And those are the most common autonomic symptoms that our Parkinson's patients will come in. And some of these are pre-morbid, are very common before they're even diagnosed with Parkinson's disease, like constipation. This may be present for many years before they're even diagnosed with Parkinson's disease. There's some good research looking into, likely early synuclein changes in the gut, myenteric plexus, years before there's ever any actual synuclein pathology in the brain. And so constipation is very common in Parkinson's disease, probably related to the disease itself, sometimes exacerbated by medications. And that's important to look at these things too. We'll talk about some of that. Again, orthostatic hypotension tends to be a big complaint, particularly with not necessarily early on, although with older patients, they may have it early on, and particularly if they have comorbid diabetes and those sorts of things. But as the disease progresses, autonomic failure can occur in Parkinson's. It's not just in multiple system atrophy. So we see symptomatic orthostatic hypotension is very common, as are urinary symptoms, particularly, nocturia and urinary symptoms during the day, overactive bladder, and even urinary incontinence. And so those are things that we'll cover in regards to Parkinson's disease. And so, again, constipation is not specific to Parkinson's, just like orthostatic hypotension is not. So functional constipation is another thing that primary care doctors take care of, clearly way more than I do, and have much more experience. It's very common in the general population, and really is just defined as 2 episodes of any kind of difficulty with defecation per week, or fewer than 3 spontaneous bowel movements per week. And so the prevalence with this increases with age. So again, the higher we get in age with our patients, the more likely we are to have some of these things with as many as half of octogenarians. And it does have significant effects on quality of life and can cause significant morbidity. Chronic constipation can be responsible for a lot of the encephalopathies we see in these patients, and it is often overlooked. In patients with Parkinson's disease, again, there's kind of a range of the prevalence, 37 to 80%. And a lot of that probably depends too on which kind of subset of the patients we're looking at. So if you have 50% octogenarians, probably close to 50% of my patient population are approaching that as well. And so those are probably the ones that it's present up to 80%. And again, significantly affects quality of life in those patients, more than even bladder dysfunction in some reports. And so here's a little kind of algorithm of constipation and treatment and management of constipation and neurological disorders. And I think the first step is the one that I find most important, and also, where in providing Parkinson's care, where the team approach and really the importance of the primary care doctor comes into play. I'm by no means an expert in gastrointestinal disorders, and I do definitely rely on our primary care doctors and our gastroenterologists to help with this. A lot of cases, patients have, pretty straightforward complaints of constipation, and we can, start with the next step to include side effects of anticholinergic medicines. And that's, it's common, and you'll see when we get to the next slide that we talk about treatment of other autonomic dysfunction like overactive bladder. There are a number of medications with anticholinergic side effects, and I presume that the talks from our memory disorders doctors have also addressed, the importance of this sort of thing. So when we look at, these medications, this can also contribute to constipation. So, in general, do they have other GI issues? And that may be, may rely on us to lean on the primary care doctors, or even, get a gastroenterologist involved if there's any concern. If it's fairly straightforward constipation, we look for exacerbating factors like medications that we could potentially stop. And then gastrointestinal intervention. And so this, is the part where, as a Parkinson's specialist, more so than you would maybe see with a general neurologist, I'm a little more comfortable talking to patients about the bowel movements and the importance of this. And so exercise, again, is one of those things that everybody wants a pill to make something go away quickly, but exercise is very important for my patients for a number of reasons. And this is one of them, as is staying well hydrated, which I don't think is actually listed here in this list of things intervention wise, but plenty of exercise and fluid is a very important factor for a number of things for our Parkinson's patients and just older patients in general. Dietary fiber, and then, bulking agents, whether it be fiber supplements. I recommend Miralax a lot as a kind of, not a bulk former, but to kind of help with, hydration within the gut. There has been a recent paper published in one of the movement disorders journals that actually shows some good evidence that probiotics do indeed help with constipation in Parkinson's disease. So I've recently started recommending that as well. that tends to be the extent of kind of my recommendations. If patients still have significant constipation after, over-the-counter things, increases in fluid and exercise and probiotics, that's when I usually start looking for help. This slide contains, here I have circled in red about prokinetics for this slow transit constipation. And I don't use this. I know there was a lot of issues with this medication, Tegaserod. I'm not even sure that it was on the market anymore. I do not use this or prescribe this. If I reach that point is when I generally then make a referral to gastroenterology if it's beyond what the primary care doctor is comfortable doing as well. And then, that's where you get into things like Botox for the sphincter and suppositories and that sort of thing. And so definitely something important to recognize. There are often other medications. Now, this mentions on here anticholinergic medications. The other big thing, obviously, to look for is opiate medications as well. And so a lot of polypharmacy in older patients can exacerbate these issues. It's definitely a common problem in my patients with Parkinson's. There are some interventions that I will often pursue or that primary care doctors will often pursue. And these folks, again, may need further specialist treatment with the gastroenterologist for refractory symptoms. So next, we'll talk about lower urinary tract dysfunction. And so the term neurogenic bladder is an oversimplification. So we see that a lot. And I have a lot of patients come in with Parkinson's and they say, well, I saw the urologist and they said it's just my Parkinson's. And it's frustrating to them because although that may kind of be a true statement, it doesn't help with, okay, well, what's next? And so depending on the site of the lesion in the neuroaxis, there's different patterns of dysfunction. So a suprapontine lesion, for instance, like what you'd see with NPH, versus spinal cord injury patients, infrapontine but suprasacral, versus, sacral infrasacral, which is going to, be often things you see even with like diabetic neuropathies or associated autonomic neuropathies from that standpoint. So you can have overactive bladder and or overactive or underactive, sphincter. And so urodynamic testing can be important to kind of determine not just that it's neurogenic, but what's overactive, what's underactive. Because just because somebody has Parkinson's disease and has urinary incontinence doesn't mean that they have the typical overactive bladder. And if you treat that again with anticholinergics, you may actually just cause them to, retain more urine, become more prone to urinary tract infections and worsen their constipation. And with the wrong anticholinergics can also, induce delirium. So again, it's not enough to just say you have this problem. I typically employ the help of a urology specialist to perform urodynamic testing and determine what's the etiology and help with management from that standpoint. I will give a plug to our urogynecology group here at Norton. I think they're excellent with this, and I've had great success for my female patients when it comes to this sort of thing. So, if you have this kind of issue, they're very good at addressing this. So, when we find these sorts of things at bedside, history taking and a bladder diary, and looking for symptoms that are specific, non-invasive tests such as, a urinalysis or a bladder scan and in-out catheterization. Those are not things we can readily do here in the neurology clinic, but are things that can readily be done in the clinic, for instance, in the urology clinic. And sometimes that's enough without, more sophisticated urodynamic testing just to confirm that there's, no post-void residual and they're having symptoms most consistent with the overactive bladder. And if that's the case, there's conservative treatments, again, behavioral therapy, nobody ever really wants to pursue. These anti-muscarinic, anticholinergic agents tend to be the usual, and you'll see a list of those on there. I tend to try to avoid those for most of my patients because, again, they're older and do have a tendency to have some cognitive impairment. The exception is the one there at the bottom, trospium, which is trade name Sanctura. The molecule of that is really too large to cross the blood-brain barrier, so it can have systemic anticholinergic effects without having CNS side effects. It does tend to be a little pricier than those like oxybutynin, but that's my favorite if I'm using an anticholinergic. There's the beta-3 receptor agonists, and that's basically the trade name Myrbetriq. Do monitor that. We'll talk a little bit next about orthostatic hypotension, and that one is associated with supine hypertension in those patients. So again, something that has to be watched. Desmopressin is something that's showing up newer. I've not used that before, but could be used. And then tibial nerve stimulation and Botox injections, again, are things that are done by the specialist urologist or urogynecologist, as well as surgeries and that sort of thing. So there are kind of a number of areas. And again, I find that there may be a couple of medications you can try if you can document just some basics that it's clearly, overactive bladder related to Parkinson's, but I almost always want to get a specialist involved in this so that we're treating the correct thing. And now to the last one, orthostatic hypotension, which I think is the big one. Again, for me in my clinic, it takes up the most time more than those other two, although those are more prevalent and probably is very common across the board as we look at things like the diabetic autonomic neuropathy too. So by definition, when a person stands up, gravity pulls blood into your legs and that causes your blood pressure to lower. And that happens to everybody, but most of us are able to kind of quickly increase our blood pressure and not really have symptoms. Orthostatic hypotension occurs when the blood pressures remain low. And so it's defined as a sustained reduction in the systolic pressure of 20 or a reduction in the diastolic pressure of at least 10 millimeters of mercury within the first 3 minutes of standing or a head up tilt on a tilt table. Now, obviously, I don't do a lot of tilt table in our patients, because most of this we can have them do occasionally in the office. Although I find the best time to do these is really at home, and getting patients to do the work and do the blood pressures to diagnose this is often tricky, particularly if they're older and have some cognitive impairment. But this diagnosis requires blood pressures, and that's it. There's not, they don't need carotid ultrasounds or MRIs of the brain or anything else. They just have to take blood pressures and a heart rate. Heart rate's important, not for this, but for the neurogenic portion of that. So it's not a symptom. They may have orthostatic dizziness, but it's a sign. So it's a clinical sign, and it's done by vital signs, and it indicates volume depletion or impaired peripheral vasoconstriction, or both. And so when it impairs perfusion to the organs above the level of the heart, mainly the brain, is when it causes disabling symptoms. And that can be pre-syncopal symptoms, dizziness, lightheaded symptoms, and even syncope and passing out. And obviously passing out increases falls and increase in morbidity and mortality. So this is an important thing to recognize. Any patient that complains of being dizzy ever should have orthostatic blood pressures taken. So it's frequent in the elderly, kind of like we talked about with some of the other things like constipation and a variety of medical conditions. The intravascular volume depletion is probably the big one, just being dehydrated, not drinking enough. Blood pooling, varicose veins in the legs, venous insufficiency, that sort of thing, tends to increase this. Anemia as well. So anemia is often overlooked as a contributor to this. You have decreased oxygen carrying capacity, and so therefore higher blood pressures than would normally be symptomatic can be, anti-hypertensive medications. And a lot of these older patients have had hypertension since they were younger, and as they've progressed, they may not have hypertension as prominently, and they're tending towards lower blood pressures, but their blood pressure medicines have stayed the same. Physical deconditioning. And so in all these patients, the blood pressure issues improve dramatically or resolve if the underlying cause is treated. And so recognizing these things, you might be able to actually resolve that problem. In a minority of those patients, this drop in blood pressure is due to reduced norepinephrine release in those postganglionic sympathetic nerves. And so because of this, they have defective vasoconstriction when they stand up. So the blood vessels don't respond, and usually there's not an appropriate cardiac response either. So, ordinarily we stand up, our blood pressure drops, the autonomic nervous system says, hey, our blood pressure is low, our blood vessels constrict, and our heart beats faster, and we compensate for that. When that doesn't happen, this is referred to as neurogenic orthostatic hypotension. It's most frequently seen in patients with diabetes. In my clinic, again, also we see it in patients with disorders of alpha-synuclein, and really most commonly in Parkinson's disease. Parkinson's disease prevalence being much, much higher than multiple system atrophy. And so, traditionally the name Scheidegger syndrome was assigned to people with autonomic failure, But it's probably that term is not really used anymore. And multiple system atrophy is reserved for people who have presenting syndromes of severe autonomic failure. It's very common for me to see people with advancing Parkinson's disease also have autonomic failure and not have MSA, but really struggle with a lot of these things. Other small fiber neuropathies caused by amyloid or autoimmune or paraneoplastic diseases can contribute to this as well. But most commonly it's going to be diabetes, and again, in my clinic, Parkinson's disease. So it can, in Parkinson's patients, orthostatic hypotension can occur in probably over half of the patients, and is frequently aggravated by the medications. I don't use dopamine agonists very much at all. I find that their side effects are outweighed by their benefits, and I tend to use levodopa, but both of those can. Monoamine oxidase inhibitors are probably minimal for that, but definitely, starting patients on Sinemet, we have to monitor for orthostatic hypotension, particularly if they have, a tendency to have these symptoms before the diagnosis is made, and that can occur in our older onset patients. And this results in a large burden of occult morbidity, including things like falls or fatigue or cognitive difficulties, and just vague symptoms sometimes, leg weakness or kind of shoulder pain, what's called coat hanger pain. A lot of these things are potentially symptoms that are vague, and I often will screen patients that just have complaints of general malaise or fatigue just to make sure that it's not something that is occurring. So symptoms of orthostatic hypotension, again, are from lack of blood flow or hypoperfusion, primarily of the brain. That's the dizzy, lightheaded, cognitive slowing, and syncope, but also, visual pathways, the blurry vision from either retina or visual pathways in the brain. And then even upper body, muscle. So ischemia, basically, to those kind of, that coat hanger pain is really muscular ischemia that can be caused by this. Fatigue and even some dyspnea because of hypoperfusion to the lung apices, and occasionally even in angina related symptoms from ischemia, coronary ischemia. And so the definition of this is defined by an increase of at least a half a beat per minute for each millimeter of mercury of fall in systolic blood pressure, which is why it's important for obtaining a heart rate. So if the heart rate goes up accordingly, then it's not neurogenic in nature, and it's really just volume depleted. The management of this, again, documenting that what they actually have is neurogenic orthostatic hypotension, and then non-pharmacologic treatment, including volume replacement, salt replacement, looking at other medications, iatrogenic causes. And then, if the patient's not volume depleted, or if they are volume depleted, you can use Florinef, but they still need the volume. If they're not volume depleted, I don't check plasma norepinephrine in patients just because it's not readily available. Patients with a elevated plasma norepinephrine helps to differentiate from MSA, but ultimately most of these patients we're going to treat with midodrine. Droxidopa, trade name Northera, is generic now. I have found that it's really not a whole lot more effective than the midodrine, and is less easy to get a hold of in these patients. And so I use a lot of Florinef and midodrine. Not on here is Mestinon or pyridostigmine, which helps a little bit without exacerbating supine hypertension. So medications to reduce intravascular volume and trigger vasodilation can worsen orthostatic hypotension. And again, this is any number of medications we use, antidepressants, medicines for erectile dysfunction, and even like alpha blockers that are used in BPH can contribute to this. Medications we use sometimes like tizanidine, beta blockers, and then levodopa. And again, the other thing is anemia. Oxygen carrying capacity and blood viscosity are both reduced. And so this can be a big contributor as well to worsening these symptoms. Non-pharmacologic treatments we kind of have reviewed already: increase water and salt, make changes to physical activity. Abdominal binders and compression hose and that sort of thing are often recommended. I'll be honest, I don't use them much because I find that my patients can't really get them on. You know, the calf high types of compression socks just really don't help. They really need compression really up to the waist. And if they don't get that, they don't get a lot of benefit. And most of them can't get those types of garments on. And so they have an expensive pair of stockings that hang in their closet. Frequent small meals is another thing that I added to this slide, which can help because postprandial hypotension can be exacerbated as well. And so here we I mentioned before about multiple system atrophy and the use of this. Basically, Strattera is the drug. They have the norepinephrine reuptake inhibitor, and then pyridostigmine that we'll add sometimes as well. And then finally, kind of just a mention of supine hypertension, which is often comorbid because of the lack of ability of the autonomic system to account for that. And so treatment with short-acting antihypertensives at night, and then cautioning patients about getting up in the middle of the night, particularly if they're getting up for nocturia, and potentially worsening the orthostatic hypotension.